Jane, what is it that you do when you have students on clinical attachments? What is it? What can you tell me about your role? What is it that you do to help facilitate student learning while they're attached to you in a clinical placement?
Well, it's fairly broad, and we do it in lots of different ways. So the first thing is you need to know what level they're at, and so you need to know what sort of skills they've got so that you can start working on those. So we have third years and fourth years, they have different skill bases. So the first thing you do is you work out where they're at. Now, you know where they should be at, but one of the things you want to work out is where the individual students are at. So we're really wanting to give them the chance to come and do two things: be part of our team and to see how the team works, and to learn by watching what everyone does. But separate to that, they've got to have the experience of seeing the patient and doing the thinking for themselves, and then coming back and getting feedback about that. So we do two things. The first thing is that they will come on the ward rounds with us. So there would be myself and a junior doctor and them on the ward round. And in that situation, if they have seen the patient, so say we see Mr. Smith and Mr. Smith is one of their patients, then they get the opportunity to stand at the door and tell me all about Mr. Smith before we go in to see him, the same as the junior doctor would. So in order to do that, they've got to first see the junior doctor do it a few times, and then we say to them, now on the next ward round, you'll be able to do that with one patient that you've had a chance to see. So you sort of give them the modelling first, and then you let them have a try. Then the other thing is that they've actually got to go and see the patient and take the history and examine them. Now, they've done it all in clinical skills down here, but as they said to me, but they're not real people, they're telling you stories and they don't have any signs. And so we actually do two things. We send them off to see the patients. We say, go and see Mr. Smith, take a complete history, examine him from top to bottom, and then come back and sit down and write it all out like you were writing in the notes as the resident, and think about trying to make the diagnosis. Now, when they've done that, they then come and find me and say, all right, I saw Mr. Smith and can I present him to you? So you actually have already taught them in lectures at the beginning of the year how to present the patient. So they present it, and then you're trying to develop their ability to think about putting together the history and the examination to come to a differential diagnosis. And then you're wanting them to think about what tests they have to do to work out what is the actual diagnosis from the differential, and then how they're going to manage it, and how they're going to manage it in the context of the whole person and using the whole team. So there's all these different stages. So what I try and do is, when they come back, is to work out from how they're presenting it where they're at. So supposing they come back and they go, oh, Mrs. Bloggs has had chest pain. You go, all right, what sort of chest pain? Now, if they say, oh, just chest pain, you go, well, do you know a way of working out what a pain is like? Oh, yeah, there's that Socrates thing. They taught us that. Okay, well, if you did a Socrates on her pain, what would you know? And they go, oh, well, it's in the middle of her chest, and it's this severe, and then they go, oh, I didn't ask her this, and I didn't ask her that, and I didn't. So you say, all right, well, do you want to go back and ask her that? And then tomorrow when we talk about it, you'll know more about the pain. But let's go through the other bits. What about what you found when you examined her? Oh, she didn't want me to examine her. And you say, oh, well, why was that? And so what you're trying to do is you're trying to get them to reflect upon not only what information they got out of the thing, but what other information they need, and then how the interaction with the patient went. And that's often the hard bit. There's some people, they walk in and they say, the ones that have been physios before and they're learning to be doctors, well, they know all this stuff. They've chatted to patients before they know how to persuade people to get up and walk on painful legs, you know. Whereas the ones who've been accountants before, they don't have the same skill set. So those are the sort of things that we're aiming to do, but it's a very slow process where they go away and they come back, and the difficult bit is to encourage them to think about it.
And what do you do if you find that their reflection on their knowledge and skills and the way they've interacted with the patient is a bit different than the way you're perceiving their abilities?
Well, I guess I actually try and focus on what they did well. But there is this thing that it's quite well known that if you say, look, you did this well and this well and this well, but they only ever hear the bit after the but. So it's much better if you can get them to somehow come to the knowledge themselves. So I say to them, well, I need to know this, this and this, and, you know, can you tell me that information? That's a very good way of them suddenly going, oh gosh, I didn't think to ask that. Well, that's okay. I often don't. So I say to them, I often don't remember to ask things. I said, you'll see me on the ward round. I'll come out of the room and I'll go, oh, bother, I forgot to ask the patient if she's ever been on Fosamax. And I go back into the room and I say, gee, I'm hard to get rid of. You know, have you ever had this medicine? And they'll go, oh, yeah, the doctor tried that, made my stomach upset. And I said, so, you know, it's never a problem to go back and ask them another question, except probably in an exam. And, you know, we're here to teach you to look after patients, not necessarily to pass exams. So the other thing I think is that if we can get them on the ward round with us, they actually see what we're doing. So for example, when we go round on the ward round, I go in and I sit on the patient's bed and I chat to the patient. Now I have this really interesting thing because I'm teaching the junior doctors at the same time as well. And in the rehab ward, which is where I mostly am, you get them to write the notes. Like the junior doctor's job is to write the notes, and then if you say, right, we need to check this blood test, they do it, and then when you come back on the next ward round, they tell you what the result is, or if it comes back and it's a problem, they ring you up beforehand. Okay, that's one of the things that the students learn to do. So when you go in there and you sit on the bed and you chat to the patient, I've discovered that the residents write in the notes, seen by Dr. and with my name, continue rehab. And so I'd say to them, what do you think we would have liked written in the notes today? And they go, well, you didn't do anything, you just sat on the bed and talked to the patient. So clearly they've come from another discipline where the doctors rush around and look at the wounds and say, yes, you'll be out of hospital tomorrow, rather than my sort of discipline where you actually have to engage the patient in what is often quite a painful, tiring, difficult, frustrating, awful process, which if they don't get through, they're going to end up in residential care. So a lot of what I do is sitting and chatting to the patients. So I say to the students, all right, well, what did we talk about? Well, you know, usually if it's Monday morning and it's winter, I talk to them about the football. And you see the students looking askance, and we get outside and I say to them, why did I ask them about the football? And they look at me and they go, I don't know. Or they look at me and they'll go, oh, because you're being nice, or because you like the football. And you sort of go, well, no. Mr. Bloggs likes the football. He barracks for Essendon of all teams. You know, why would a West Australian barrack for Essendon? And they go, how do you know what team he barracks for? And I go, well, I've looked after him 4 or 5 times now. So we chat about the football because he's interested in the football. It makes it apparent to him that I'm interested in what he's interested in and how he's going as a person. And it also tells me whether he's still engaged in his usual interests. It tells me how his memory's going, if he can accurately remember how much Essendon got thrashed by yesterday. And the students always look at me and go, oh, I thought you were just being nice. You know, and I say to them, they used to tell us to ask them who the Prime Minister of Australia was. And in my particular hospital, all the old gentlemen used to say to me, don't know, don't care, none of them are any good. which didn't really help me assess their cognition. So those sort of things that they pick up on the ward round, they've got to do with your style. So one of the difficulties is that you may get a student who doesn't like your style.
Uh-huh.
You might get a student who knows that they want to be an orthopaedic surgeon and they can't see why you're sitting and chatting to the person when you could be getting round nice and quickly and going off to do another operation or whatever.
So do you ask the students to reflect on your style, that they're observing your style of interacting with the patients?
I do. I don't actually say to them, please reflect on this, because they hate the word reflection. But what I do is when I come out of the room, I say to them, why did I ask them about the football? Or why did I ask Mrs. Bloggs what she's knitting? Or why did I admire that new photograph there? Or, oh, gee, it was your birthday yesterday. Who came to visit you? And I actually try and get them to tell me why I might do those things, and then we talk about it.
So there's lots of learning opportunities that just occur spontaneously in the corridor as you're walking along, rather than structured lessons.
Yeah, and that's one of the things that they find difficult. It's like, but I want to do hearts in the first week and respiratory in the second week. And you go, well, this week I happen to have a patient with a stroke and one with Parkinson's and one with cellulitis in their legs. So that's what we're going to learn about. And so what we do have to do is to make sure they get exposed to everything is towards the end of the term, we keep track of what they've seen. And then we say, gee, you haven't presented a case with diabetes yet. What about you go and read up about diabetes and then tomorrow you can tell me about this? Or Dr. So-and-so's got a really good patient with diabetes who said she wouldn't mind, and so we will swap between teams so that they get the opportunity to see all the common things.
Uh-huh.
The uncommon things we have to cover other ways. We have to do paper cases where we use photographs of or other means, because you can't guarantee that in a 9-week term they will necessarily see everything.
So it's the balance of that spontaneous learning, but also them getting the breadth of what they need exposure to while they're there.
Yeah. Now, the ones that are really keen, that will do what I encourage them to do is see the patient, go away and read about it, and then when they read about it, they'll suddenly think, oh, I didn't ask my patient if they have numb feet when they're diabetic, for example. They'll go back and ask her the next day and she'll say yes or no, but they'll remember forever that if you ask a patient about numb feet and diabetes, that will help you work out whether they've got a peripheral neuropathy. Whereas if I tell them, you should have asked this patient about numb feet, they won't remember it.
It sounds to me as if you're facilitating their responsibility for learning while they're there.
That's the plan, yeah. The other thing we do is we try and encourage them to go around with the resident, and so then if you get a good resident and you're teaching the resident, you encourage the resident to give them opportunities. So you say to them, remember when you were a student you loved putting in the drips? Well, when you've got a drip to put in, ask the student if they'd like to do it for you. Now, at my hospital that means the resident's got to actually go and stand and supervise them. So it actually takes more time for the resident to do that. But I remind the resident that it takes longer for me to do the ward rounds teaching them, or that people did it for them in a very nice way. But you remember when you were a resident how hard it was to get opportunities to do things, Or do you remember when you were a student how much you really liked to admit the patients? Well, these are final years. They can admit the patients for you and then present to you, right? And if you can get everyone engaged in the process, then people feel, much more committed to it. They know that if they help the students, you help them and everyone learns. But also the students can be really helpful. And I actually remind the students that every time I do a ward round, a student tells me something about one of my patients that I didn't know. They say, oh, do you know that Mrs. Brown's son chopped his finger off at work the other day? And I go, no one had told me that. But Mrs. Brown had told them because they're her student and they come to see her every day. And it's quite common for students to actually tell us things that we don't know. What isn't common is for people to remind the students how useful that is. And I've had students say to me, oh, I got to deliver a baby. It's the first time I felt like I was doing something useful. And you go, well, actually, on the medical ward, when you take a history and examine the patient and write it in the notes, you're doing something useful.
So you're facilitating the students' learning and also their engagement with the team and the team's engagement with them, and then the patient, their interaction engagement with the patient.
Yeah.
So there's all those aspects of a clinical attachment to come together that you're the central person for, really, aren't you?
Well, I guess so. I mean,
while you're imparting the responsibility, you're the facilitator.
Yeah, I'd like to try and make sure that all the team are engaged in it. And like when the physio students come on the ward or the OT students come on the ward, they come to my team meeting, they contribute to the meeting, we ask their opinion if they're looking after that patient, the same as we give the medical students the opportunity to present the case briefly if they're looking after the patient.
Which gives them the sense of belonging and belonging to an overall outcome for a patient that's made up of lots of people contributing.
Yeah, and I think when they enjoy it like that, they actually get more out of it. When they feel like they're a nuisance and that they're in the way, which sometimes happens, then they're not as willing to hop in and do things. They don't get the same experience.